I just feel that understanding your medication is really important. So use your pharmacist, ask them to explain what's happening. That's what we're there for.
Welcome, everybody. My name's Drew Bailey. I'm the TOF's chair, and I've got the easiest task this evening, which is just to briefly introduce the webinar and to close out things at the end as we round off. As usual, if you've got any questions as we go through the discussion, then please put them in the Q&A chat function online. I'm going to hand over shortly to the panelists, and they'll introduce themselves in a moment, and then we're going to go into the Q&A session that Duncan, Vice Chair, will host or compare. I'm sure Duncan will introduce himself properly as well. So we've had some really good questions, but as I say, please pop some questions in the Q&A function as well. And without further ado, I'll pass over to Christian and Anja, who can introduce themselves and kick off the session.
Thank you very much, Drew, and thank you everyone for inviting us here to speak to you this evening. My name's Christian Chadwick. I am the lead pharmacist for neonatal care at the Royal Sussex County Hospital in Brighton, as well as the lead pharmacist for neonatal care across Kent, Surrey and Sussex. And I work alongside the other regional lead neonatal pharmacists on the National Neonatology Committee for Pharmacists as part of the Neonatal and Pediatric Pharmacists group. So yeah, that's me, and I'll hand over to Anja.
Oh, thank you very much for asking us to come and talk to you about the medication and the specialist group you are is going to be really interesting. I'm Anja St. Clair Jones. I'm a consultant pharmacist in gastroenterology. I've been working in gastro for over 10 years and been practicing for a very long time. I'm partly retired, but I'm really, really passionate about, research and that we all are getting involved in research and therefore, considering some of the questions, we are needing the data you can give us as patients and with the coming of AI, the more data we have about outcomes of treatments, about the effectiveness, about how they work, the more we understand it. So that's really where I come from. And we are happy to take your questions.
Okay, thank you both. And obviously, thank you for joining us. Welcome, everybody. I'm Duncan Jackson, I'm Vice Chair. I've been involved now with TOFs for over 20 years. My daughter's now 24, so gone through all that process of childhood and obviously into adulthood now. So I'm still intrigued by some of the questions and some of the, and obviously we're looking forward to your answers on them because it does affect her, particularly some of these. So the first question was, what's the long-term effects of a pump inhibitors and their use in children, and how can you manage those?
So I just go quickly first, and then obviously Christian as a neonatal or as a pediatric pharmacist knows more. But I would just like to say we only really licensed or got PPIs, proton pump inhibitors, in 1988. That's when they first was licensed. To them being used with children usually takes nearly 10 years before they are sort of routinely used with children. So we actually only have 25 years probably of good experience of long-term PPI use. So humans live till about 70. So we really don't totally understand what long-term use means. We have signals of what problems we have, but overall, as I said, we need the data. We need your data because you adapt special group. And I'll hand over to Christian, and obviously together we'll sort of highlight.
Yeah, and I'll talk you through what we do know from the experience we have and the data that is available at the moment. And so I'll go through things in sort of all the possible long-term risks that we know about and what data there is to explain those and support that risk that we know about. But I just would start by saying this, with every medication, there is always a risk, short-term and long-term risks. And every decision to use a medicine and to take a medicine is a balance between the potential benefits that you'll receive from them, but against the risks that they might pose. So although some of this might sound scary, or some of this might be things you know out all already, it's always a balance between the likelihood of that risk against the benefits that you would receive from them. But if I just go through some of the long-term side effects that we do know about, and the first one is to do with infection risks. So the way a proton pump inhibitor works and how it affects the body, you reduce the acidity of your stomach. And by reducing that acidity, you're reducing one of your natural barriers to infection and to bacteria getting into your lower GI tract, and there is an increased risk of infection. And from the studies that are available, there's one reasonably good study in children, which compared infection risks in gastrointestinal infections to children who have been taking long-term proton pump inhibitors to children who haven't, and it did demonstrate an increased risk, an increased rate of gastrointestinal infection. So in the children who had been on proton pump inhibitors, they demonstrated 47% had experienced a GI infection versus 20% in those children who hadn't. So there is a clear increased rate of infection there. And we've also got some other data in there about where gastric fluids and other bodily fluids have been analysed, and sort of that analysis of bodily fluids is something that is part of research that is quite easy to do compared to other types of research, the longer term controlled trials. And there was a study looking at the bacterial growth rates in gastric fluids, so the fluids from your stomach, and comparing it to fluids from other body systems. And they compared really like for like against respiratory fluids, so any of the secretions out of your lungs. And they did demonstrate that there was increased rates of bacterial growth in stomach fluids on a PPI compared to not being on a PPI, but in the same children, respiratory fluids, there was no difference. And theoretically, that makes sense. You're reducing the acidity, so you're reducing the hostile environment to bacteria, so there's going to be an increased chance that they will proliferate in your stomach acid and your stomach contents. So the risk is it's not saying you're definitely going to get an infection. It's that the risk is higher, but you still have lots of other body defenses against infection. But one of them has been reduced. And then the other thing about infection, there's a condition called small intestinal bacterial overgrowth. So in the highest part of your intestines, just underneath your stomach, once you've emptied that and into the tops of your intestines, it's still quite a rare condition, but where a infective bacteria sort of over-colonizes and takes over where the normal gut microbiome and the sort of big sort of lots of different bacteria would be living all harmoniously together. You get an overgrowth of one particular bacteria. There's some very small studies in children. There's only 3 papers that report it. And so they're just looking at really individual cases of children where that has been, where they are identifying that children on PPIs they're starting to suggest that might be a contributing factor to that condition. But interestingly, there is a huge amount of data from the adult world on that. And there was a analysis of 3,000 adults on proton pump inhibitors, which showed a just over 2-fold increased risk of that condition when taking a proton pump inhibitor or not. That's my blurb about infections. So next on my list of long-term complications is nutrient deficiencies. So proton pump inhibitors can affect your ability to absorb vitamins and minerals. So, and that's again due to the change in acidity of your stomach. So if the acidity changes, the chemical reactions between things you eat and ingest, and how your body reacts with them from a chemistry point of view changes, because the amount of acid and alkali and the buffering is all different. And so there are certain vitamins and minerals that you become less able to absorb, and the risks from that really are reducing the density of your bones, and for the longer that goes on for, the higher your risk of fractures to bones would be. And one of the key minerals that you struggle to absorb is iron, so you're at high risk of anemia as well in prolonged use of a proton pump inhibitor. These are things that should be being managed and monitored for if you are using a proton pump inhibitor long term as part of your medical reviews. Sort of your bone mineral density and your routine blood tests should be keeping an eye on this, and if it is becoming a problem, it can be managed. Two more on my list of long-term complications, and one is to do with allergic tendencies, and this is actually a large amount of data from the USA, where they looked at 14,000 children who had been exposed to proton pump inhibitors within the first 6 months of their life, and they identified that they were identifying increased risks to tendencies for food and medication allergies, allergic rhinitis, hay fever, and asthma. And that was sort of exposure in the first 6 months. There was an increased risk to have developed that by 5 years old. And the other thing was actually from the same data set, the same study of those 14,000 children across the USA, which showed a increased risk from obesity with proton pump inhibitors. And actually, this is quite an interesting statistical nugget to share, because when I say it, it'll sound not so bad, and then I'll explain it. So the report shows that there's a 2% increased risk of obesity taking the proton pump inhibitor versus not. If you read the headline, that's what it says. Actually, when you dig into the data, it's 2% for every month you're on a proton pump inhibitor for the first 2 years of your life. So it's a cumulative 2% per month over that time. And that's really interesting, because those huge numbers of data do support that being a more statistically sound data. But all of these complications are things that should be being in the minds of people looking after you when and reviewing you through your care, and reviewing your medication use, so that they can be managed and mitigated if there are signs that these are starting to occur for you. Not they're all risks, they're all possible, they're definitely going to happen. And as I said at the beginning, it's always about a balance of how much benefit you're receiving from that medicine, and what the risk is, and what evidence there is of any adverse effect happening. So I'll just throw that in again, because I'm really not trying to scare anyone.
No, I agree. For me, it's, how much does it affect your quality of life? What happens if you don't treat your reflux, which is definitely cancer? We know that if acid goes up into your esophagus, it changes the tissue, and therefore it's like a wound, and any wound changes the tissue, so it's not the striata cells anymore, which it should be. Therefore, your cancer risk is much, much higher. And that's what we're worried about in gastro when we talk about esophagitis. With the infection, I would say everybody's gut flora is different. We to be honest, we don't understand the gut flora, but we know that the stomach is an important barrier, and we just need to understand and manage this. So SIBO, so the bacterial overgrowth in adults, is much more recognized. When I first started, you were very odd if you got it diagnosed, because it just wasn't. And now it's very common. So the awareness in the healthcare is much more. And with the obesity, I just would like to say, any drug or any medication we use, they're never really specific to just one thing. So the PPIs prevent acid production, the pumps which put acid into the stomach prevent that. But we also know that they work in the liver on fat metabolism and all sorts of things. So, the longer we use a drug, the more we understand it. But again, the data is very patchy on something like the cancer. There are some data which says it's cancer protective for gastric or for intestinal cancers. Others says it isn't. We just don't know. On some of these, what we want you to do is be very careful and think about anything that's not normal. Discuss it with your health team, with your healthcare team. That's the most important thing. You know your body best, so anything that's you just feel is not right, don't just ignore it. Go and ask, and it could be. Hopefully, it's nothing, but rather earlier than later.
Thank you both for that. Yeah, I absolutely agree that, you know your body best and you know your child best and you know when they're not right and when they're not right and you are their best advocate for that. So if we look at the next question, I'm going to sort of move the next two together because obviously it's talking about omeprazole. I presume lamprazole is an American sort of spelling or is the same sort of drug. I'm presuming because I've never heard it before. And then obviously we've got lansoprazole being talked about later. But what are the long-term effects of omeprazole? And I'm quite interested because obviously my daughter was on it, certainly omeprazole, for 12, 13 years. She was on a daily dosage and then we reduced it. So the person who asked this question said, should we be worried about our child's future from taking any of the PPI drugs? Christian, do you want to start and then Anja follow on?
Yeah. I think the most important thing to be sure is and this is for omeprazole or any of the PPIs, already any medication that anyone is taking long term, is that it is under continuous review. And as Anja said before, if something changes and you're not right, is to speak up and try and address any problems early. So the long-term effects that I discussed before but they're the same for any of the proton pump inhibitors. They are a class of medication, and the way they work, it doesn't really change very much between the different individual medicines because of their unique way that they work in the body. The long-term effects you would expect to be exactly the same for all of them. So omeprazole, lansoprazole, or some of the newer ones like rabeprazole, pantoprazole, you would expect those long-term effects that I talked about before to be the same. But as long as there is a good regular system of review, and that includes reviewing the medication and looking at the potential for the adverse effects. So looking for signs of anemia, looking at bone risk, and taking steps to mitigate that if there is the startings of feelings or the starting of evidence that there is a problem there. So things like the decreased amount of iron that you absorb that can lead over a long time to anemia, that can be managed with dietary changes, and if necessary, iron supplements. Iron supplements are another medication and have other complications, but there's definitely a room for dietary involvement to look at what are iron-rich foods to prevent that. So in terms of should you be worried for your child's future, I think as long as you are engaging in, and both you and the healthcare team that you're under are engaging in regular reviews that look at the whole picture of health, including the medication use and their risks, then there shouldn't be any reason to worry.
And I agree, there are lots of sort of theories about dementia, cancer risk, whatever. Just also think the trials compare people on these medications with often with a healthy population. Well, they don't behave the same way and will not respond to the medication exactly the same way. We've got that in different scenarios where they said, they all cause cardiovascular problems if you're on a PPI, but actually it showed that they're just sicker people who are on PPIs than the ones who aren't. So just be very, very careful with getting worried about side effects. The same with dementia. We just don't know. There is no evidence pro and for, and what we have is very sketchy. The only, yeah. So the other thing, I think that's probably all I was going to contribute. Oh, the healthcare is now really going for, shared decision making. You should be listened to if you have worries, and the decision has to be yours. That the quality of life and the risks and benefits should be clearly laid out to you about what it means taking it, not taking it, the side effects, and how this might potentially. And everybody's different, not everybody reacts the same way.
Yeah, I mean, at the moment we are sort of coming to the end of the era of using medication in a blanket way, where this is the medication that would treat the general population the best way, and doesn't allow really for tailoring to the genetic variabilities between us all. And I mean, look at us, we're all completely different genetically. So Anya's got much more hair than I have, that sort of thing. But right now is the real time of acceleration in genetic and genomic medicine, where people's individual characteristics are starting to be analysed in. At the moment, it's still very few disease states, but the research and the practice and it leading into healthcare practice is really accelerating at the moment, where actually treatments can be more individualized to people, and we will understand the risks that are higher in some people and not so high in others, and know which medications are the safest for each person, in a much more individualized way. At the moment, choosing a medication is based much more on population level data and the likelihood that it will work the best in the safest way, based on looking at everyone we've ever seen taking it and that sort of thing. But times are changing.
And the PPIs are a really good example of those. They get handled through a group of enzymes which are called CYPs, and everybody is very different. And we know some people are what we call high metabolizers, so they get rid of it very quickly, and others are really slow metabolizers. But we don't know unless we measure the enzyme, however, who's what. But if we had your genetic makeup and we know what information in your genes determines which one, then we could really tailor it much more. And that's where really healthcare is going, with the genetics and AI collecting much bigger data.
Okay, thank you for that, both. Next question. How detrimental to the gut biome is taking PPIs, and can this contribute to the worsening of indigestion, reflux, and obviously poor health into adulthood?
I'm happy to take this because can it contribute to reflux? Reflux can have several causes. The most common one is that actually there is a problem with the valves which stop the acid from the stomach at the top where the esophagus joins the stomach, which is just where your diaphragm is. So the stomach is under the diaphragm, the esophagus is at the top, and then there are two valves. Some of them they're controlled partly by the diaphragm, partly by other muscles. And if they don't work well in tandem exactly right, or if they're floppy or whatever, the acid from the stomach can go into the esophagus. So it's in a way, it's that bit is mechanical. Or if the stomach goes through your diaphragm, which the hiatus hernia, the valves can't work properly. This can be partly managed by lifestyle. Often hiatus hernia is losing weight. It can be done by surgery with fundoduplications. So there's the surgery which prevents this happening. But there are others which are not just the mechanics of or the physiology of your stomach. There are other refluxes which are due with your immune system. So I know we're talking a little bit about the Eosinophilic Oesophagitis later. So, reflux isn't just reflux, but bacteria doesn't seem to do too much unless Christian knows more around it. We lifestyle. So of course any lifestyle changes help, and but the actual microbiome I don't think is that much involved in the reflux.
Yeah. the microbiome itself and contributing to reflux, there's nothing I know of that will affect it that way. The treatment with a PPI we know will affect what the makeup of your gut microbiome is, and will change it compared to what it would have been without a PPI. Different bacteria will get from ingestion through your food and whatnot through your stomach and into your gut, and what effect that has and how much the PPI, the proton pump inhibitor, affects that. It is really difficult to unpick because there are so many different parts of your life that will affect your gut microbiome. So it's not just in terms of medication, it's not just your proton pump inhibitor use. One of the big things that would affect it is your antibiotic use. If you are a very, very sick newborn baby that spends weeks and months with someone like me on intensive care, then you're likely to be exposed to a higher burden of antibiotics, which will affect your eventual microbiome formation and proliferation compared to a baby born at term who has no antibiotics until they're months or years, hopefully old. And the development of that microbiome and which bacteria form it will be different. But and that's just medication, that all sorts of other factors, your environment you're exposed to as you grow up, your diet, it's all so individually dependent that it's so hard to say exactly what the effect is and what differences are due to what lifestyle exposure for you as an individual. So we know that the gut microbiome is different for people on certain medications to people not on those medications, and that's for all sorts of different medications, including things like omeprazole. But how much is down to the medication and how much is down to all sorts of other factors is certainly at this point in time impossible for us to tell with the sort of methodologies and scientific knowledge and techniques available to us.
Exactly. I mean, we just don't understand the microbiome. We know you need a certain amount of a certain number of a certain kind, but then also they need to be in the right balance between the different kinds. And it is a really, really delicate but very effective system for us to absorb food, to fight off, diseases. It's really linked, and we're only just scratching the surface. And my normal microbiota is definitely not what Christian's is, but we know that in families your microbiota adapt, so you probably infect each other. So it's really, really complicated. But as we say, some drugs we know will definitely have an effect on it in beneficial, sometimes detrimental way. And that's, again, if you have diarrhea, if you're not feeling well, ask for advice.
Okay, thank you both for that. Our next question is from somebody whose son is 2 years old and they're on a full dose of lansoprazole, so 15 milligrams, I presume, daily. What else can be given to help them manage reflux?
Christian, over to you.
This is me, and I'm probably not going to give you an answer that you're looking for, especially in young children, infants and babies. The supporting evidence for using any medicine for reflux is very, 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 very poor, really. The medications we use for reflux were designed and developed in response to adult reflux, where it is very much more acid mediated. And in newborns and young infants, the reasons for reflux are much more in the mechanical side of things. So the immaturity of the valves that control where the acid flows and doesn't, and how it moves through, and the coordination of the different bits of the gastrointestinal tract getting synced up, which is something that takes time after you're born. It can take months for that to sync up properly. Reflux is really, really common in newborn babies. 90% of babies will have some sort of reflux, and that will be anything from a bit of milky pus sitting in the mouth to really severe reflux. And that is mechanical, and really we don't have medications to deal with it. So what you can do for young children is more in terms of dietary positioning. So how your child is, how your baby is positioned while they're eating or having a feed. For a young baby, having a milk feed, the positioning, especially for newborn babies, having the calming influence of a parent there with it. What we see really interestingly in babies admitted to hospital as newborns and with showing signs of reflux is actually being in physical contact with the parent and having that calming influence of knowing their mum or dad is with them. It is one of the biggest things that helps us. But also we're talking about milk and liquid feeds. Thickness and volume all make a big difference. And then as you get older, what solids and what foods, and that's where really our colleagues in terms of speech and language therapy and dietetics are really helpful in being able to tease out the bits of your diet and your feeding sort of process, your procedures, your mechanical procedures of eating and ingesting and getting food in really affect. And that it's really worth speaking to those sorts of people as well. There are other medications that are very occasionally used, and they're usually reserved for when we've tried absolutely everything else, and there's really severe reflux that's having a real detriment to quality of life. But as I say, there's an increasing body of literature that show there's no difference in the general population of taking those medications or not to the severity or the frequency of reflux episodes. So in some individual cases they are shown to work, but in the population as a whole, on a general scale, there's nothing overwhelmingly supporting their use. And as they are medications, they come with additional side effects and risks.
And also, I presume, I don't know this, but I presume your child would have had surgery. This is tissue which has been traumatized. So,
yes.
it takes a time to readjust. And if there is still some reflux, I probably would go and get advice that there's nothing else going on. And
yes, yeah, and really, actually, when we start a proton pump inhibitor following surgery for esophageal atresia, it's to protect the surgical site, the anastomosis, from damage and stricture. Is the theory behind it. And I know there's a big study about to start that TOF is sponsoring to look at providing a good RCT gold standard evidence for that, which is really exciting. But that's actually the reason we're starting omeprazole following the surgery. It's not for the reflux that we start it at the point of coming out of surgery and starting to feed.
And also, you should have at least yearly reviews of your medication, and maybe can be reduced. Usually with PPIs, there is a ceiling effect. After a certain dose, there's not going to be, you haven't got any more enzymes which it can inhibit. Therefore, a high dose is often not helping. If it's not controlling it, seek advice to just make sure everything is okay and it can be managed in a different way.
Okay, thanks for that. It's just going back onto that question about, there's a ceiling limit. What is that limit that, sort of like a child can take in terms of milligrams?
So there's actually some detailed, what we would call pharmacokinetic studies, which is where we study the passage of a medication through someone's body and how our body absorbs it, what it does, how it transforms it through its journey, and how it then either weasel poos it back out the other end, really. And so there's actually really good studies on looking at how that compares from children's the effect in children's bodies, which are different to adults. A baby is different to a child, is different to a teenager, to an adult, in terms of how their liver and their kidneys and their stomach and their guts all affect that medicine. And that's something that I'm really passionate about, and So that's why I get a bit animated, because this is my jam. But the studies for proton pump inhibitors show us that one, there's quite a broad range of safe dosing for them, and so you having the therapeutic effect at that ceiling dose starts, and there's a good window up and down between patients, but also that there's quite a correlation between adult doses and children's doses, which is really rare because children's bodies and babies' bodies are so different. But it's really specific to why proton pump inhibitors do what they do, and they do what they do by inhibiting the cells that secrete acid into your stomach, and that is irreversible. So once that omeprazole has latched on and is saying stop, no more acid, it ain't coming off again. So the way for the effect of a proton pump inhibitor to stop is for your body to have recycled that cell that's been inhibited and created a new one in its place. And that doesn't change between how old you are. Your stomach will reproduce its acid cells at the same rate for your life. So that's really unique to proton pump inhibitors, that actually what your liver's doing and what your kidney's doing to them matters, but not nearly as much as it does for almost every other medicine we would use for anything. So what's my point? My point is the ceiling doses are really easy to work out, and we're really so the doses that we use. So for omeprazole, which is by far and away the most commonly used proton pump inhibitor for children, and that's because the reason we use that one the most is because that's the one we've always used the most, and no one wants to try something new because we all go, oh yes, we know omeprazole. And we go anywhere from 0.7 to 3 milligrams per kilo per day of omeprazole, and going beyond that, you're unlikely to get any additional benefit because you're already inhibiting as many cells as you can. There's no more cell to latch onto until new ones are created the next day, and then you're taking the next day's dose to do that. The lansoprazole, we go up to 1 milligram per kilo per day. So 1 milligram per kilo per day of lansoprazole is shown in the studies to be equivalent to 30 milligrams of lansoprazole in a healthy sized adult, and that's the same then for the 3 milligrams per kilo of omeprazole would be your maximum dose of omeprazole, which is 40 milligrams a day in a me-sized adult, not a little old lady.
Okay, thanks for that.
It might just be worth mentioning, yes, we have 4 PPIs available at the moment. And, if one doesn't work, it's worth trying another one, because it could be that you're just metabolizing it inappropriately or it just isn't for you. So, yeah, in the end, my argument is use the PPI that works for you.
Yes. Yeah. And with that, with as Anja was talking about earlier, the CYP enzymes that affect how our medicines are processed through our bodies, actually, with the 4 PPIs that are available, there's one of them that goes through a slightly different pathway, which is really important when you come to taking medicines other medicines alongside a proton pump inhibitor, and whether they interfere with each other inside your body and there's an interaction going on. So sometimes we might recommend a switch to rabeprazole is the one it goes through a slightly different pathway, and I've certainly had to switch when a new medicine's come along that would otherwise interact with omeprazole or lansoprazole.
Yeah. So again, that's obviously where the pharmacist on the team would come in, because this is what we're checking for.
Okay, thank you for that. It's sort of this, you've sort of answered part of this question already, because the next question is about how often should I get a medication review, and you've already mentioned about yearly getting a check on that. But the question then goes on to say about weight gain, and obviously getting medication reviews because they're gaining weight. I presume this is potentially in an adult, but I'm only guessing that. So, but it could be with children as well.
Well, the children's obviously it's according to weight, the dose. Yeah. So Christian can explain. For adults, you only have that many cells it needs to, even if you put on weight. and there doesn't seem to be a markedly distribution into fat. There is sort of they've looked at it. They think maybe if you have fat, it gets metabolized quicker, but then they thought maybe you don't absorb as much as well. They just couldn't say. So at the moment, it's symptom control. You know, if your symptom is controlled on that dose, that's fine. If not, go and discuss it. You can try a slightly higher one, or change. But Christian, for the pediatrics,
yeah. So like Anja says, once your stomach is fully developed and grown, then there's only so many cells that it can hold around its insides to do the acid. So changing the dose on weight gain, actually, as you gain and lose weight, your stomach isn't really changing size very much. So there's very little to do there unless you're seeing a loss of effect or you're seeing potential side effects, and that's more where we might change the dose as we're fully grown. So if I was seeing a teenager, which I don't do that often anymore, I only see the babies. But as you're growing, so the fastest rate of growth is when you're born, and then the older you get, the amount you grow slows down. So especially when we're starting a medication in a newborn baby, then the dose will be titrated to weight change quite regularly. And in hospital, we'll do that probably weekly, once a week, maybe once every 10 days, something like that for a drug like omeprazole. For other medications, we might do it more frequently, and for others, less so, depending on their individual chemistries in the body. But as you get older, less frequently, and certainly if you're on a stable dose, not in hospital admitted, but at home on a stable dose, and symptoms are well controlled, then in line with your routine reviews with your healthcare team, which the older you get, the less frequent they get. So as an adult, it might be 6 monthly or yearly, whereas as a child, it might be 3 monthly, and as a baby, it might be every 6 weeks or 2 months, something like that. And part of that review, that sort of holistic review of you as you or your child, should include a review of those medications and including the doses.
And I might probably want to say that with very big weight gains, then the physics of the gut, the stomach being squeezed through the additional weight, or you know, that then makes a difference on the reflux, because all of a sudden, you know, you're changing the physics and the pressure on the stomach to go into your so you know, lifestyle. Look at your lifestyle is always worth probably as good as a drug.
Okay, thanks for that. Right, next question. Can you take omeprazole daily and azithromycin in prophylactic dose for life? This person's asking, their son is 5 and both have been prescribed indefinitely.
So for the omeprazole, I think hopefully we've sort of covered that before, so I might focus on the azithromycin there. The azithromycin itself in prophylactic doses we see in many different conditions that is used long term, and as medications go, it's on the safer side. There are fewer risks, but it isn't risk free. No medication is risk free, and this will depend really on the frequency of infections and things. So azithromycin should be being used to prevent infections, and usually respiratory infections. So if things are settled down and stable, then azithromycin hangs around in your body for a really long time after you've taken it. So if you take 3 days in a row, that's going to and then stop. It's still going to be there's still going to be an effective dose in your body 7 days after you took the first one, and the more you take, the longer it lasts. So if you're taking it usually 2 or 3 times a week in a preventative dose, in the lower risk points of the year in the summer where respiratory infections are less likely, you can take drug holidays to allow your body to start washing some of that out and reducing the risk of long-term effects for azithromycin, which the major ones are on hearing. So With azithromycin, it's reversible hearing effects. So if you do notice any especially with a child, if you notice they're off balance or complaining of a ringing in their ears, and so you think, oh, thinking, is this tinnitus or something like that, then it's worth pausing and trying to get to see your healthcare team to investigate that. And the other thing is around long-term use and effects on liver function. So as part of routine reviews on someone on long-term azithromycin, there should be liver function monitoring in their blood tests.
And also always discuss this with your healthcare team, because it also might be that the recommendations are going to change in the future because of resistance, but that's what our path lab or our labs or public health labs are looking at, resistance patterns. And they are so important, these prophylaxis things, that, yes, drug holidays are great, but do it together with your healthcare team.
Oh, yes.
Like Christian said,
Okay. That's brilliant. Thank you. The next question. Do you know what treatment, and this is for an adult born with OA and long gap as well. So what treatment can they get for, I think I'm saying this right, eosinophilic esophagitis?
Yeah, okay. So eosinophilic esophagitis is different from reflux. It's not mechanical. It is a reflux, but it's more about probably an autoimmune response to some stimuli which we don't understand, but your tissue in your esophagus is infiltrated by white blood cells, these eosinophils, which cause the inflammation, and it doesn't really respond well to PPIs. What it responds to are steroids, and the steroids is not. There's no point in giving you systemically. The side effects of steroids systemically is far too high for the effect. So they are now, in the past, before we had the beclometasone dispersible tablet, which is specifically done for eosinophilic esophagitis, we used inhalers, beclometasone inhalers, and instead of really breathing it into the lung, we said swallow the spray, because it coats your esophagus. So this new drug, which is called Jovisa, which hopefully you've been tried, it can only be prescribed by specialists. And the idea is it's a slow dissolving oral dispersible tablet. So you keep it in your mouth, and over a certain amount of time, you just slowly swallow this beclometasone, which coats your esophagus and therefore deals with this inflammation, which is for some reason been triggered, and they don't know if it's food, some kind of food or environmental effects or something which triggered. We just don't understand it, but we know it is not. And funny enough, I looked it up. There is now a biologic which America has approved. It's in trials. It's called dupilumab, DUPILUMAB. It's used for in dermatology for atopic eczema, and the trials are there for looking how it works in eosinophilic esophagitis. So there is something possibly in the pipeline. It won't be for a long time, I can tell you, with NHS, because there will be, there is a lot of, they are expensive and the benefit risks need to be balanced. So they need to look at the data. Is it as effective or more, or is it more effective than what we have? And can we put the funding in, because the long-term effect of not dealing or not using it is much more expensive than not. So that's what NICE does. So yeah, we recognize it much more. When I first started, nobody had heard. Well, it was sort of something odd, and you just sort of made a little solution and got people to sip it, and now we're much more aware on, and it's probably much more often diagnosed than it used to be and in the past you just said you had reflux, and now it does get investigated. It has to be through a biopsy. So you have a OGD, esophageal, a camera down your throat, and they will take biopsies to see what the histology, the cell pictures looks like, and it will be infiltrated by these eosinophils. Does that explain?
Really clear.
If OA is going to affect it, as long as you are able to coat most of the active esophagus. I presume you have a kind of stent with OA. It's not much pressure. So, if you can get
it would depend on the gap and whether it's just an end-to-end anastomosis or whether there needs to be a grafting of something.
Exactly, yeah.
Depending on how big the gap was at birth.
Yeah, they did say it's long gap, so there's probably going to be some.
Yeah. So is there any esophagus at the end, which needs to be also coated? It's just the specialist will be able to talk to them about this. But we have good results with Teresa in our patients. So
Okay, that's great. Thank you. Our next question is: how long should my son take Losec? A surgical team advises me to stop, but I don't think I should, as he has reflux.
I think any change to taking a proton pump inhibitor like Losec, which is omeprazole, if you're using it long term, then it should be a gradual. So it definitely, if you're worried, especially if you're worried about the effect of stopping, is to reduce dose and then reduce frequency over a period. So often if someone's been on proton pump inhibitor for a long time, you might take the dose down to half of what it is for 4 weeks, and then maybe take it down from doing it every day to just doing it when symptoms are bad for 4 weeks, and then trying to stop it. There is a risk of rebound reflux if you've been using a proton pump inhibitor for a long time. It's difficult to give exact advice because obviously we don't know your son and what the history is and how long things have been going on for. But if you're concerned, always talk to them. Talk to the surgical team if they're advising it. Ask them to give you the breakdown of their decision. What has prompted them to give you that decision? What's the rationale behind it? It's one of the core principles of the NHS in general is no decision about me without me. So if you're not happy with a decision, then you can talk to them, and no one should be objecting to you discussing a decision. Generally all of us in the NHS are here to try and help and do our best to get the best results, and that involves that your body's the best, your children the best. So if you don't think something's right, talk to them. Yeah.
Okay, thanks for that. Right, we're going to put a pause on the questions just for 2 minutes. You'll have seen another name appear on the screen, which is John Pearce. John, for those of you who don't know him, he has been a trustee of TOF for a long time and has stepped down, but he's doing a lot of volunteering still for us. And one of the things he's doing, he's working on the TOF project, which of course is a lot of research. So we just thought it'd be quite nice for him to, as he's on the call and on this chat, for him just to talk for 2 minutes about the actual project. So John, good evening and welcome, and over to you.
Hi, good evening all, and thanks for the opportunity to say a couple of words. Yeah, indeed, I'm the TOFs volunteer. I've been representing TOFs to the TOAST project, believe it or not, for 5 years now. It hasn't quite started yet. It's going to go on for more than that time once it has started, but there's a very serious hope it'll be starting this summer. The whole point about the TOAST project is to find out the answer to a question which I put as a layman, not a doctor, as a layman, to my mind, the question which TOAST is trying to answer is it a good idea to give all babies who've had surgery for OA this PPI drug, or is it a better idea to just give them a PPI drug when there's a specific reason for that particular baby of giving them that drug? What goes on at the moment is that there's an international recommendation that says giving that drug is a good idea, but there's no research really behind that recommendation. It's a general feeling from some experts. And there's a lot of suggestion that actually it might not be a good idea for all babies to have this drug unless they've got a particular evidence of need. So what happens in Britain at the moment is that something approaching half of the babies in the UK who have OA surgery are given this drug as a routine by their surgeons because their surgeon thinks that's great. And the alternative is something approaching half, we don't know exactly how many, are only given a PPI drug if their surgeon and the rest of their team think that particular baby needs it. So it's a bit of a lottery going on at the moment. And the point about the TOAST trial is to try and have a proper randomized controlled trial, in other words, a gold standard trial, gold standard study, to try and work out what is the sensible thing to do. It's going to go on for quite a while. It's quite a big thing. It's UK specific, but many of the big hospitals in the UK are going to be involved. And hopefully we'll get some meaningful answers to this particular question. I'll leave it at that for now and see if anybody's got any further comments or questions they want to put.
That's fantastic. That's just up Christian Street.
Yeah, I mean, I did a lot of reading about the TOAST trial before tonight because I sort of knew in the background that there was something, and I read up much more about it, and it just looks like a fantastic trial. So I really hope we're one of the centres that's going to participate. I have no idea whether we are or not, but I hope we will, because it is one of the conditions we look after here in Brighton quite, yeah. So I hope we are taking part and joining in the journey.
I mean, I'm really excited that, you know, you as a charity are championing this research. And who's leading it? Who's got the grant?
The grant is actually, for what it's worth, with Oxford University, but the principal investigator is Professor Nigel Hall, a name which I'm sure is very widely known. So it's led by surgeons Nigel Hall and his colleague Ian Yardley, who's a surgeon at the Evelina. And the people who are running the trial in terms of its day-to-day organisation are the National Perinatal Epidemiology Unit at Oxford.
Brilliant, yeah. Well, Christian, you need to get in touch with them.
Yes, it's actually really interesting because probably at the same time as the feasibility work for the TOAST study was being done, bit of a meta-analysis of the evidence that currently exists for using PPIs post OA surgery was led by someone called Tom Wiley, who was actually my counterpart for Wales. So what I do for the southeast of England, he does for Wales, and I know him very well. And that analysis, it was a review of all the literature that had been published on PPI use post OA surgery in babies, and it really showed, one, there's not a lot. There's nothing. None of it really shows anything that you could draw a statistical conclusion from, and the study designs were all subject to quite a lot of bias in the methodology, so really difficult to actually draw conclusions from the publication. So actually, the TOAST trial is going to fill a really well needed gap in the evidence for the medication we use.
Well, it's lovely to hear that from somebody who is taking an interest in this, but not as part of the team. So that's most interesting. Thank you.
Thanks for that, John. Obviously, we need to get back to the questions because time is ticking on. So hopefully, we're going to run over a fraction. So Christian and Anja, I hope you're all right for another 5-6 minutes. I know you've got another call, Christian. Are you all right, or are we struggling?
We'll make it work. Yeah.
Okay, so we'll be quick. We've already answered much of the next question anyway. How much PPI is too much? Our medication's been doubled after a pH study, and they're on 22 milligrams a day for a 13-kilo child. So you pretty much answered that, but if you just want to reiterate.
Yeah, I mean, that would be a little way above our normal maximum dose. So I think the important things to note there are actually for individuals that might be okay. The variability in us as people may actually require a little bit higher dose in certain individuals over the rest of the population in general. But again, especially with following a dose change, we should make sure we're keeping a good eye on, is there any change in effect? Is there any change in anything else that's giving us a sign that we're having any side effects? And just being mindful, especially for the first sort of 2 to 4 weeks of that dose change, that has anything changed, saying that there's an improvement in symptoms, in which case, hooray, that actually is a benefit to you. Or has nothing changed in symptom control, and so if nothing's changed, then actually we're at the ceiling dose, and there was no more effect to be got out of the medication. So there's probably not much benefit in continuing on a higher dose, and it's really to make sure you're keeping on mind on those things and any other changes in your child's sort of health or behavior that you might be able to link with it and go, actually something's different, and go back to the healthcare team and discuss it with them either way around.
Okay, thank you for that. Next question is, what are the latest, most effective recommendations for PPI medications?
So actually there are a few small studies that compare the different proton pump inhibitors to each other in terms of their effectiveness, and actually there are some that show in very certain patient groups or very specific conditions that one might be slightly better than the other. But if you look overall across proton pump inhibitor use in general, especially in their wide ranging use for reflux, there is no difference. In terms of their effect on blocking the acid suppressing cells, it's more what suits you as a person in terms of its effect on the rest of your body, and whether you experience any side effects from it or not. The clinical effect on your acid suppression between the different medicines is negligible.
Whereas I sort of looked, is there anything new coming? Because, I mean, for us, they're really old drugs. They're 20 years old, which is new, but it's still. So there is a new drug coming, which again, in America has been approved because they're slightly more gung-ho. It's a potassium competitive acid blocker. So instead of the PPIs, which is a proton pump inhibitor, which is, once it's inhibited, that's it. This potassium competitive acid blocker, so it competes with the potassium, so that the receptor prefers it slightly to potassium, but it probably can be, moved away again. So it might not be a full block for the end of the cells, but it seems to work slightly faster. Currently, the license is time limited, so it's only available on trials in this country. I think I can't remember. One of the London hospitals does it. So that's one. The other one was a new surgical thing where they basically help put a sort of a surgical pack into the stomach to prevent the acid going up, so help the valves and help the whole physiology. So that's really the only new things in PPIs.
Okay, thank you for that. And sadly, we're on to our final question. So I'm going to say thank you, because obviously after this, I'm going to pass back to Drew, who's going to finish everything off. But it's been absolutely fascinating talking to both of you, and obviously listening to everything you said. And hopefully sometime perhaps in the future, later this year or even early next year, we could perhaps come back together again and do another session, and so we can answer all the other questions, particularly that have been gone into the Q&A and things like that. But our last question, which was submitted to us, is, what are the signs of silent reflux?
I mean, for me, it's when you have sort of like a lump in the throat, you're coughing, there's no reason why you should be coughing. You have a sort of, it's post-nasal discharge, because it's just anything in your throat that doesn't sound right. It could be silent reflux, so you actually haven't got the heartburn, but it's damaging the cells of the esophagus. Difficulty swallowing, hoarseness, or even taste change can be it.
Bitter taste, isn't it?
Yeah.
That you can often find with silent reflux is you find a bitter taste really at the back of your mouth that persists.
Yeah, that's okay for a child or an adult who can say what it feels. It's much more Christian finds it, how do you do it with babies?
Yeah, and with babies, certainly in the early stages of a baby's life, actually the natural process of developing as a baby, whoever you are, and no matter how you're born, is your stomach is a little bit less acidic than you are as a bit older child or an adult, and that's because we know that's sort of a naturally evolved mechanism to protect the baby as much as naturally our bodies can, whilst your swallowing and your stomach movements and your gut movements will sync up and actually get into a regular process. So there's already a little bit less acidic there. So it's actually, once that period of your life ends, months into life, when your stomach starts to become more acidic, contents become more acidic. And so the signs you'd see for reflux in an infant or a toddler might be things like really fussing at feeds, refusing feeds, frequent, like little bits of posseting, milk in the mouth is absolutely normal in a baby, but bringing up large volumes of milk, projectile vomiting, and then moving on to signs that actually feeding is causing discomfort to the baby. So classically, you'd see an arched back, so like bringing themselves upwards off the cots and with an arch in their back, crying that you cannot settle, inconsolable, high-pitched crying. Some of the classic signs for reflux in a baby who's a few months down the line. You don't really see that in newborns because they have that natural protective mechanism that makes the pH in their stomach that bit higher and that bit less irritating to the esophagus.
And also, I would really urge you, if you have any of these signs, to go and seek advice, because it could be something else. You don't want to avoid strictures. If you have an anastomosis, you don't want to miss strictures. You don't want to miss changes in polyps, whatever it could be. It could be all sorts of things which need to be excluded. It's not right.
Yeah, I mean, all the symptoms and signs we've talked about for adults and children, there are signs of silent reflux, but they're also they can also be signs of other conditions as well. So, and they are quite serious. They can be quite serious. So it's definitely worth getting checked out if you're concerned.
Okay, thank you both. Crew?
So really just to say thanks, Christian and you, and also thanks everyone for attending. And if you can fill in the survey that pops up, or you'll get an email tomorrow, just take 5 minutes to fill that in afterwards. And obviously we're recording, so if you're watching it on YouTube, then obviously please like the video and subscribe to the TOS channel. So we'll close there. So thanks again, everybody.
Thank you, everyone.
I just feel that understanding your medication is really important. So use your pharmacist, ask them to explain what's happening. That's what we're there for.
Yeah. Hopefully you've seen, we're really happy to get into the science about it. Yeah.